Good morning, everyone, and welcome. I'm Dr. Asim Hassin, and I'm glad you're here today. We'll be discussing toxicology emergencies, specifically focusing on opioid overdose and toxidrome. Over the course of this presentation, we'll cover the key signs, symptoms, and management strategies for these critical situations. Let's get started and explore this important topic together. All right, let's look at this case. We have a 34-year-old man found unconscious, and his vital signs show some concerning features. His breathing rate is only 6 breaths per minute, which is significantly low, indicating hypoventilation. His oxygen saturation is 82% on room air, clearly showing hypoxia. The pupils are pinpoint, which often suggests a central nervous system depression or specific toxin effects. His blood pressure is within normal range, at 110/70. When we piece these together, the key points are the shallow breathing, hypoxia, and pinpoint pupils. These signs point toward a specific type of poisoning or overdose that suppresses the respiratory centers in the brain and causes pupil constriction. As we go through the options, it's important to recognize the pattern here. This presentation is classic for certain drug overdoses, and understanding these signs helps us quickly identify the cause in real clinical scenarios. So, keep these features in mind as we continue to explore different toxicological emergencies. The correct answer here is B, which is marked with a check. Now, let's talk about why. Classic opioid toxidrome typically presents with a few characteristic signs. First, patients often become comatose, meaning they lose consciousness and are unresponsive. Second, pinpoint pupils are a hallmark feature, very constricted pupils that stand out. And third, respiratory depression is a major concern, as opioids can significantly slow breathing, which can be life-threatening. Recognizing these signs is crucial for timely intervention. As we move through this presentation, keep in mind how these classic features help us identify opioid overdose quickly and accurately. Now let's look at this question. We have a patient who is still bradypneic, meaning their breathing rate is slow. The question asks us, what is the most appropriate immediate treatment in this situation? Looking at the options, we have several antidotes and interventions. Flumazenil IV is used for benzodiazepine overdose. Naloxone IV is for opioid overdose. Sodium bicarbonate is typically used in certain poisonings, like tricyclic antidepressants. Activated charcoal helps remove toxins if administered early. And intubating without an antidote is a more invasive approach, but it might be necessary if the patient is airway compromised. The key here is to identify the cause of the bradypnea. If we suspect opioid overdose, naloxone IV is the most effective immediate treatment because it rapidly reverses opioid effects, especially respiratory depression. This choice aligns with our overall theme of timely, targeted intervention. It's essential to recognize the cause quickly so we can choose the right antidote and prevent further respiratory compromise. So, in this case, the most appropriate immediate treatment is B, naloxone IV. The correct answer here is B, which is the key point to remember. Naloxone works quickly to reverse opioid-induced respiratory depression, which is often the critical issue in overdose situations. It's important to understand that while naloxone can restore breathing, airway support might still be necessary. Sometimes, additional interventions like airway management or ventilation support are needed even after administering naloxone. This underscores the importance of acting swiftly and comprehensively in overdose cases. Remember, the overall goal is to stabilize the patient and ensure they are breathing adequately, so always be prepared to provide further assistance if needed. All right, so in this scenario, after giving naloxone boluses, the patient keeps becoming drowsy and shows signs of hypoventilation. This indicates that the opioid effect might still be significant or perhaps worsening. The key here is understanding that repeated hypoventilation despite naloxone suggests we need to act quickly to support the patient's breathing. Now, looking at the options, starting an infusion of naloxone could be considered, but typically we first want to secure the airway and ensure adequate ventilation. Giving flumazenil is specific for benzodiazepine overdose, but there's no mention of benzodiazepines here. Starting antibiotics doesn't fit this acute neurological or respiratory picture unless there's an infection, which isn't indicated. Observing without intervention is risky because the patient's respiratory status is deteriorating. Therefore, the most appropriate next step is to support the patient's respiration immediately, usually with airway management and ventilatory support, rather than just observing or administering additional medications. This underscores the importance of prompt respiratory support in opioid overdose management, especially when hypoventilation persists despite naloxone. The correct answer here is B, and let me explain why. When we're dealing with long-acting opioids, it's crucial to remember that they can cause prolonged sedation. To manage this safely, we often need to use naloxone infusion. This ongoing infusion helps prevent resedation, which is a real concern because as the opioid effects wear off, patients might become sedated again. By maintaining a continuous naloxone infusion, we ensure the patient remains responsive and avoids dangerous respiratory depression. This point ties into our overall theme of safe opioid management and highlights the importance of vigilant monitoring and intervention to prevent adverse effects. All right, let's look at this scenario. A patient receives a large dose of naloxone, and suddenly they become agitated, hypertensive, and tachycardic. This reaction might seem surprising at first, but it actually makes a lot of sense when you understand what naloxone does. Naloxone is an opioid antagonist, meaning it blocks the effects of opioids. When given in large doses, especially if there is still some opioid in the system, it can cause a sudden and intense withdrawal reaction. This withdrawal can manifest as agitation, increased blood pressure, and a rapid heart rate. So, connecting this to our options, the most fitting explanation here is acute opioid withdrawal. It's important to recognize this because while naloxone is life-saving in overdose situations, it can sometimes provoke these withdrawal symptoms, especially if opioids are still active in the body. This highlights a key point in managing opioid overdoses. While naloxone is crucial, we need to be prepared for the possibility of withdrawal reactions, especially in chronic users. Understanding these responses helps us balance the benefits and risks when administering naloxone. The correct answer here is C, and let's talk about why. Naloxone, as many of you know, is used to reverse opioid overdoses, but it's important to remember that it can also trigger some significant reactions. Specifically, it can precipitate acute opioid withdrawal. This means that patients might experience symptoms like agitation, vomiting, and even hypertension. These responses are part of the body's sudden reaction to the rapid reversal of opioids. Understanding this is crucial because while naloxone is life-saving, we must also be prepared to manage these withdrawal symptoms. It ties into the overall theme of safe and effective overdose management, knowing not just how to reverse an overdose, but also what to watch out for afterward. Always keep in mind that withdrawal symptoms can be quite distressing, and proper supportive care is essential. Now let's look at this question about opioid overdose. The table presents several features, and we need to identify which one mandates ICU admission. The options include pinpoint pupils, vomiting, recurrent respiratory depression, mild bradycardia, and drowsiness only. The key point here is that while some symptoms like pinpoint pupils or mild drowsiness are common in opioid overdose, they don't necessarily require intensive care. Vomiting, although concerning, can often be managed in a regular setting unless it leads to aspiration or dehydration. However, recurrent respiratory depression is a serious and potentially life-threatening feature. If a patient experiences recurrent episodes of respiratory depression, it indicates that their breathing is significantly compromised, and this is what truly mandates ICU admission. Similarly, mild bradycardia might be manageable, but if it progresses or is associated with other signs, it could become critical. So, the most important concept here is recognizing that recurrent respiratory depression reflects a severe, ongoing compromise of vital functions, making ICU care essential. This ties into our overall theme of identifying the signs that demand urgent and intensive intervention in opioid overdose cases. The correct answer here is C now. Let's break down why that's the case. When a patient is experiencing ongoing respiratory failure or requires a naloxone infusion, it's crucial to recognize that these are signs of significant instability. This isn't something we can manage safely on a general ward. Instead, these situations demand close monitoring and immediate support, which is best provided in the ICU. So, the key point to remember is that persistent respiratory issues, or the need for naloxone infusion, indicate a level of severity that warrants intensive care unit management. This ensures the patient receives the appropriate level of care and continuous monitoring to prevent further deterioration. This concept ties into the overall theme of recognizing critical signs early and escalating care appropriately to improve patient outcomes. Let's take a closer look at the toxidrome associated with opioid toxicity. When someone is experiencing opioid overdose, you'll notice a characteristic pattern of symptoms. First, there's a decreased level of consciousness or altered mental status, which can range from drowsiness to unresponsiveness. Next, respiratory depression is a key feature. This is when breathing becomes slow and shallow, and in severe cases, it can even stop altogether. Another hallmark sign is miosis, or pinpoint pupils, which is quite distinctive in opioid overdose cases. These features collectively form what we call the opioid toxidrome. Recognizing this pattern quickly is crucial because it guides us toward the right intervention and can be life-saving. So, understanding these signs helps us connect the symptoms to opioid toxicity and reinforces the importance of prompt diagnosis and treatment in these scenarios. Let's talk about some common pitfalls to watch out for when managing opioid toxicity. First, over-reversal can be an issue. Sometimes, if we give too much naloxone, it can cause the patient to swing into withdrawal, which can be quite uncomfortable and potentially dangerous. It's important to titrate carefully to avoid this. Next, we need to remember that naloxone has a relatively short half-life, often around 30 to 90 minutes. This means that resedation can occur if the opioid's effects outlast the naloxone. So, close monitoring is essential even after initial improvement. Another crucial point is always considering co-ingestants. Patients might have taken other substances alongside opioids, which can complicate the clinical picture and affect how we manage the toxicity. Finally, keep in mind that opioid toxicity isn't just about the opioids themselves. Co-ingestants can influence the severity and treatment response, so a comprehensive assessment is key. Overall, understanding these pitfalls helps us provide safer, more effective care. Now, let's talk about management in cases of opioid toxicity. The first priority is securing the airway and providing oxygen to ensure the patient can breathe adequately. If the patient is hypoventilating or showing signs of respiratory depression, oxygen therapy is essential. Next, we administer naloxone, but it's important to titrate it carefully to restore respiration without causing abrupt withdrawal symptoms. The goal is to reverse the respiratory depression, not to fully arouse the patient immediately. In cases involving long-acting opioids like methadone, we may need to consider a naloxone infusion to maintain reversal over time. This helps prevent recurrent respiratory depression as the drug continues to act. Monitoring should be continuous for at least 6 to 12 hours, and longer if methadone is involved because of its prolonged effects. Keeping a close eye on respiratory status and consciousness levels is crucial during this period to ensure patient safety. Ultimately, managing opioid toxicity requires prompt action, careful dosing, and vigilant observation to prevent deterioration. Let's talk about pearls in managing these cases. First, always treat the respiratory rate, or RR, and not rely solely on the Glasgow Coma Scale, GCS. RR gives you a real-time picture of the patient's breathing effort, which is crucial. Next, be very cautious with flumazenil. It's contraindicated in mixed overdoses, meaning if you're unsure whether benzodiazepines are involved along with other substances, avoid using it because it can cause adverse effects. If the airway is unsafe, say the patient is struggling to breathe or there's an obstruction, don't hesitate to intubate. Securing the airway is always a priority to prevent further deterioration. When it comes to opioid toxicity, the key is recognizing the signs early and providing appropriate reversal agents while monitoring the patient closely. Remember, these pearls tie into the overall theme of safe and effective management of overdose cases. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. Remember, the key points we've discussed highlight the importance of understanding the core concepts and applying them effectively. I hope this presentation has inspired you to think differently and take actionable steps forward. If you have any questions or want to delve deeper into any topic, please feel free to reach out. Once again, thank you for being here and for your engagement throughout.